Well, good morning and good afternoon, everyone. My name is Glenn Farrant. I'm the CEO and co-founder of CriticalArc, and it's my honour to present the webinar today, which is the inaugural webinar in a joint venture between IAHSS and IACLEA. The topic of the webinar, obviously, with the associations involved, is collaborating across organisations where there are related healthcare and higher education institutions who need to collaborate on the safety and security of their people in each of the environments where they have duty of care. In the time that we've been working with organisations across the globe, across the last decade or so, we've been delivering the Safe Zone solution across many healthcare and educational organisations. We regularly will sit with the Chief of Police or Director of Security, and more often than not, there's a relationship between a healthcare organisation and a higher educational institution, or multiple relationships. And it's always a topic of conversation about how safety and security is managed across and between these organisations. So that's really the topic of conversation here. We've been working with IAHSS and IACLEA over the last 6 months or so to foster closer relationships and to bring more value to all of our members so that we can improve the capability of the industry where this challenge exists. We have an esteemed panel here today. We'll have each panel member introduce themselves shortly rather than have a double introduction. But I would like to thank everyone for their time today, and especially the panelists who have taken time out to present. So without further ado, we'll introduce the panel and get stuck into it. So for the panel today, if you could go ahead and introduce yourselves and also give all of the attendees here the context from where you're coming from. So your organisation, its structure, and maybe how the relationships exist between a healthcare and an academic institution. So to start with, Bill, would you like to go ahead?
Well, thank you very much, Glenn, and it's an honor to be here with such a distinguished group of individuals. My name is Bill Adcox. I'm the Vice President, Chief of Police, and Chief Security Officer at UT MD Anderson Cancer Center and UT Health here in Houston, Texas. I started my career in the El Paso Police Department, retiring from there after 20 plus years at executive position of Deputy Chief. I moved over to the University of Texas at El Paso, a large academic research institution with a Division I sports. I spent 5 years there and now have been in this position in academic medical and hospital operation for 19 years. UT MD Anderson Cancer Center is one of the top cancer treatment and research organizations in the world. And UT Health is a large academic medical operation that has 6 different distinguished colleges. We operate throughout Texas, mainly in the Texas Medical Center. We have 125 plus locations between the two institutions. We also have, between the two institutions, over 32,000 staff, 4,200 faculty members, approximately 11,000 students and trainees, 3.4 million plus patient visits a year, and also around 1.4 billion or a little bit more than that in yearly or annual research investment in the institutions. We also, part of UT Health is the largest psychiatric center in the state of Texas, one of the largest in the United States, with 600 beds. And again, between the academic UT Health's psychiatric centers and MD Anderson's Cancer Hospital, that's the actual medical piece that we deal with. You asked a little bit about the connections and so forth, but there's a lot of overlap. There's a lot of cross work between the different faculty members working at both institutions, and we see just a tremendous amount of overlay in terms of technology, in terms of a lot of our processes, as well as our staff. whether it's how we screen employees to work at both institutions, all the way up through taking care of a threat case involving one of the top faculty members or whatever it might be. And you have accreditation at both institutions. Some a little bit different. You have the academic side, which focuses a lot on a lot of the federal laws such as FERPA and a lot of the CLEAR Act and the Campus Safety Act and stuff. And then on the hospital side, you have obviously the Joint Commission, CMS, a lot of the HIPAA, the health related laws, the Mentala, so forth, the things that go on. So there's a lot of overlap. There's also a lot of differences and things that have to be taken into consideration. But I'll stop there and turn it over back to you, Glenn.
Great. Thanks, Bill. Appreciate that background. Mary, over to you.
Good morning, and thank you for having me. I'm Mary Parody. I'm the Chief of Police and the Executive Director of Public Safety at the University of Mississippi Medical Center in Jackson, Mississippi. I started my career in 1986 as a Chicago police officer. Worked for 11 years in Chicago. I was an intelligence investigator. And then love had it all, where I married a Secret Service agent and we moved to Washington, D.C., where I served for 25 years. It was supposed to be 4 in different organizations, in law enforcement, in higher education, with hospitals. Most recently, I was the chief of police at George Washington University. And that's kind of where I got my higher ed intro. So it's great to have, as Bill said, a combination of city law enforcement or municipality and then higher education. I think that really gives you a holistic approach to whether you're dealing with federal, state, or local law enforcement. To have that background really has helped me throughout my career. About 2 years ago, I was recruited to Jackson, Mississippi to modernize their police department. And wow, have I been able to do that. It reminds me of 1986 when I started on my career at the Chicago Police Training Academy. So the world's my oyster here, and having healthcare, research, and education all on one campus. Today, my boss and I were at a meeting and we have 20,000 people on campus today. Some of those are our patients. Some of those are our students. Those are our researchers, that's faculty. It's a really dynamic institution. Yet we're surrounded by the city of Jackson, Mississippi. As you probably have read in the local press and national press, it is the murder capital of the United States per capita. So we have a lot of challenges in the area that surrounds our healthcare center education, which is really interesting, but also keeps us on our toes, I think. And I think that oftentimes when we're running healthcare and research, we forget about the student population. And the student population is extremely important to me. And educating the students for not only while they're doing their residency here, while they're being educated here, but when they go out into the world and what kind of toolbox do we give them to deal with society? So we've really taken an approach of looking at the students as they complete their residency, their education here. How do we prepare them not only for Jackson, Mississippi, but for the world? So I think today is going to be a great collaboration, and I'm looking forward to learning from my colleagues and talking to our folks in the audience.
Brilliant. Thanks, Mary. Appreciate that. Over to you, Doug.
Hey, thank you. Appreciate that, Glenn. Good afternoon to some and good morning to others. My name is Doug Johnson. I'm the superintendent for the Department of Public Safety for IU Health in Indiana. We're headquartered in Indianapolis, Indiana. We have 18 hospitals, approximately 36,000 employees, and we think that it's a moving target, around 450 offsite locations around the state. Like Bill and Mary, I came up through municipal policing. I retired from the Indianapolis Police and then joined the Indiana University Police Department. I had the great fortune of serving as the deputy chief at the Bloomington Division, and then also the chief at the IUPUI Division in downtown Indianapolis. So if those of you who have done it know, going from traditional policing into university policing, there's a learning curve. So then about a year ago, I had the opportunity to join IU Health, which is, we share the same name to a degree, but it is a completely different organization than the university. And then the learning curve getting into hospital policing and public safety has been interesting, and always something new comes along to keep me engaged and learning. So that's a little bit about who I am. I'm thankful to be here, and in listening to my colleagues talk, I've already got a bunch of notes taken already. So thank you.
Great. Thanks, Doug. And Tommy, over to you. I think we don't have your audio at the moment, Tommy, for some reason. Try that again. No, still no audio coming through on that side. What we might do is we see if we can resolve this the technical issue, and we'll move on. So I think what we've heard here is there's a range of scenarios with regards to the way organisations relate to each other. We've seen a situation, Bill's situation, where it's effectively two organisations integrated from a safety and security perspective, with Bill, your department covering both UT Health and MD Anderson and University of Texas. Mary across, just a very large span, and having those challenges on your periphery as well. And Doug, a scenario which we see very regularly is organisations which are related by name, and then obviously have strong relationships, but effectively they're administratively different. We also work with a range of different scenarios as well. So, for example, some of the organisations we work with is University of Colorado here in Denver, where on the Anschutz Medical Campus, there's obviously the campus police covering that large, complex campus, and embedded within that organisation or that particular location is the UC Health Hospital, very much like your situation, Doug. But where there's a private security just within the walls of the hospital, and the campus police, the university police, cover the rest of the area. So in the course of any staff member's day, say within the hospital environment, they're moving between jurisdictions and response organisations just through the course of their normal day, even though they may not consider that. So we see that. And then an example out at Stanford where public safety cover the whole large campus, but embedded within the campus is the hospital, but also the medical school as well. And in that scenario, the security for the hospital and the medical school is integrated and independent or separate from the security for the rest of the campus. So we see such a wide range of scenarios. And just to sum that all up, Bill, I'm going to steal the saying you mentioned before. If you've seen one academic medical center, you've seen one academic medical center. So that leads us into the next question and the next topic of conversation, and that is, what are the challenges that you experience? So the general question here is, what are the main challenges do you experience as they relate to the relationship between healthcare and educational institutions in managing safety and critical incidents? So what I'll do is we'll reverse the order of the first set of questions. So Doug, over to you for the first detail there.
I see how this works. Okay. As I think you probably drew from Bill and Mary's introductions, there's a lot of room for overlap and interoperability. And I think at times that's a blessing, and sometimes that can be a curse, depending on size of the organizations and the particular issue. When I think about opportunity between Indiana University and Indiana University Health relative to public safety and law enforcement, I think of things like training, planning, policy planning, continuity of operational planning, because as the other colleagues have noted, that there may very well be, in our case, an IU School of Medicine building on one of our hospital campuses, right? So you have to understand, if something bad happens to that building, like a tornado in Indiana, where are we going to move facilities to, and because if they're moving, then there'll be aspects of IU Health that are probably moving too. So opportunities there. One of the things, I just throw this in as a day-to-day in the weeds, pain in the rear end, is parking. If you have parking and students and faculty and doctors and nurses are all vying for the same land terrain, then that could be a problem. So there should be some sort of understanding between facilities or your parking folks on how you're going to manage that, because it can very well become what seems like a small issue, but a very big issue unfortunately. And then when we talk about joint operability, there's joint response requirements. So if you've got nuclear material on any of your sites, there are federal requirements for joint response due to alarms and other hazards. You have mass notification issues, physical security and access control issues. We recently had a senior administrator from the university that was caught in sort of a no person's land in between one of their buildings and one of ours that was separated by a stairwell. And they didn't have the proper access cards to get through into the hospital side of the building. And, that was an unneeded embarrassment. So those are things that need to be planned and sorted out. Shared jurisdiction from a law enforcement perspective, obviously. Compliance issues, I think it was Bill and Mary, they both have mentioned Joint Commission, HIPAA, Clery. Those are things we're all familiar with. When we're talking with our local, state, and federal partners, we have NIBRS, this National Incident-Based Reporting System issues to sort through. So those are other areas of overlap. And then accreditation. I think hospital police agencies would be smart to look at IACLEA accreditation as a standard for them.
Perfect. Thanks, Doug. Appreciate that. Tommy, I just want to check that we've got you now.
Yes, my microphone kept failing. I'm sorry.
Okay, we've got you. We've got you loud and clear. Maybe, Tommy, could you do an introduction to yourself and Vanderbilt?
Sure. My name is Tommy Sutton. I currently serve as Deputy Chief of Police here at Vanderbilt. We have approximately 120 police officers, 130 community service officers, which serve in a non-sworn capacity. And we're spread across 3 precincts, the campus proper precinct, which is a traditional campus, the Vanderbilt University Medical Center precinct, which is the medical center, and Vanderbilt Health at 100 Oaks, which is a mixed-use retail and medical space that we serve the community in.
Brilliant. Thanks, Tommy. So whilst we've got you, we'll put you on the spot for answering the question around what are your main challenges in relation to the healthcare and education relationship? Obviously, you've got within your department responsibility across both the healthcare environment and the academic environment. But obviously there's differences in security across those. Could you maybe elaborate on some of the challenges you face in moving between those environments?
Absolutely. One of the most regular challenges that we face across the campus is the way we're situated. We've got the campus that surrounds the medical center, and we're about a mile from downtown Nashville. Something may necessitate an emergency at the medical center, but not necessarily so for the campus. But because they're so closely related and people have colleagues or spouses that may work in one space or another, and we have also university affiliated schools that their children attend, when there's an emergency like the Covenant shooting that occurred here in Nashville, while the Children's Hospital may be servicing a particular population for all of the needs that they may have, and that signals an alarm and alerts and incident command at the medical center, there may not much cause such an effect on the campus, right? But still the communication is there. People want to know why they were not informed, and what protocols are in place to keep them safe, and are there continued threats. So making sure that we can communicate across all platforms and all precincts to keep people in the loop, even when there's only a perceived threat, not an actual threat, and making sure we're communicating that to the public.
Right. Yes, communication is a real challenge when you've got these mixed organizations. Thanks, Tommy. Mary, over to you on the challenges you face across these different situations.
University of Mississippi Medical Center is the state's hospital. We are the only Trauma One center in the state of Mississippi. So the state relies on our students, faculty, and our staff to be ready to go at any moment. A few months ago, we had the tornado that ripped through Rolling Fork. And so within hours, the Mississippi Center for Emergency Management Services, which is part of UMMC, mobilized a hospital. So that's a huge challenge. It's a rewarding but huge challenge to bring our students to different locations throughout the state. And a lot of times you go into situations after a natural disaster that you've never seen before, and so we have to be prepared at any moment to support not only Jackson, Mississippi, but all of Mississippi. So that's a huge challenge. And when I go through the state, they're like, wow, UMMC. UMMC performed the first lung transplant ever in the United States. We are as I call it, the Magnolia Estates Hospital. People count on us, and they count on our students and our faculty to support the healthcare mission while being part of education. So talk about across, population and having to jump in just a minute or two with a storm, a natural disaster, and mobilizing students to go out into rural communities that have been devastated. It is just, when you think about it emotionally, we have to be supportive of both sides, the education piece and the healthcare piece. And so that is really, it's challenging, but I have to tell you, after 36 years, it's the most rewarding.
Brilliant. Thanks, Mary. That's great to hear. And Bill, covering the challenges of working across these two environments.
Well, a lot's been said, and I echo my colleagues' comments, but I'd have to say just to wrap it up for us, our greatest challenge is really balancing the educational and care missions of our communities with the ever-evolving and actually fast-forming threat landscape that we're seeing. And it's really how we've kind of changed a lot of the nomenclature of effectiveness and efficiencies to really being agile and adaptive. And so to us, it's how do you balance those missions with the ever-evolving threat landscape?
Right. Just a follow-up question related to that, and this is to the panel in general. There's some, I guess, some fundamental differences in the education and healthcare spaces in the cohort and the attributes of the cohort, especially when we think about the difference between students who tend to be younger, less experience in the world, and staff who also range from young but to more mature and have seen a lot. And I'm wondering what you see as the similarities and differences, and maybe the related challenges with those two different perspectives. We have our kids going from K through 12 into the college environment. They've been through lockdown drills since they were very young. They're very, very focused on these situations on the high impact but low probability scenarios like active shooter scenarios, and concern about that angle. Whereas in the healthcare environment, we've got a lot of mature people who've dealt with a lot of things over their period of time in employment in that environment. And we all know the statistics around the rate of workplace violence in the healthcare facility. And I'm wondering, are there challenges with that younger cohort moving into the healthcare environment, and maybe what the perception of safety and security might be? Does anyone have anything they want to add on that angle? Yeah, Mary, please go ahead.
I'd love to. The Joint Commission requirement January 1st of 2022 really raised the bar on workplace violence. And it really, for me, it made it shed a light on it, like it did years ago to domestic violence. And I really appreciate that, because it really pushes us into a non-comfort zone and maybe some guidelines that we have to adhere to. So at the University of Mississippi Medical Center, we really went full throttle with making sure that we are preventing workplace violence, and we're paying attention to it with our students, especially when you spoke about students that have never really worked in a work environment. Now we're putting them in while we're educating them into a work environment. That's unique. Then the folks that they may be working side by side with may have started their career in 1986 like me. So what they would perceive to be workplace violence compared to a student that maybe was born 30 years later is very different. And so as leaders in law enforcement, we have to be inclusive of all of those people. And what may not seem like workplace violence to me, to someone of a younger generation may see that. So we're really paying attention to it. We developed a behavioral response team to respond to workplace violence. We are calculating our workplace violence stats. We're looking at the environment that these events are occurring in. Is there something that, by the Joint Commission requirement, is there something in the environment that is enhancing workplace violence? Are we doing everything we can? And then we're doing hot washes after a workplace violence occurs. So that includes that student, that includes that nurse manager. And we talk about it. What could we have done better? How could we have intervened earlier? And where I find my biggest challenge is healthcare workers do not want to prosecute the offender. And so what we have to do is our Office of Advocacy needs to work with them to ensure they know what their right is as the employee. And then we have to go full circle. And it doesn't end after the court case. It doesn't end after you visited with them. You have to circle back with the employee and check their well-being, not once, twice, make sure that they're okay after. That's kind of what we do here at the University of Mississippi Medical Center. The police department takes a holistic approach. And I'm really fortunate that the Joint Commission released those standards because it's something that I use as a template of what I need to be doing. And so I like rules. As a police officer, I like to follow rules. And then the big light on us as law enforcement is to be transparent and truthful. And we've learned that. And society expects that of us. So how do we do all those things? My officers wear BWCs, body-worn cameras, and the clinical side has become our partner on this with our Office of Wellbeing. What resources didn't we have that I've asked for in my new budget that we're now working towards? So I think it also helps you in budget planning and kind of looking down the road. So I like having rules. I like implementing new plans, and I like to see we have been very successful at.
Fantastic. Just open it up to the rest of the panelists. Any challenges with the differences between the nature of the cohorts you're protecting in these areas?
Hey, Glenn, I'd like to mention something for everybody. I know those of us on the call that work with hospitals will understand what it's like to have a patient that wants to leave against medical advice. And this is something that university officers in and of themselves and traditional agency officers don't have to deal with. But when you have somebody that wants to leave and it's really in their best interest to stay, that can cause a problem. And for hospital police officers, it rubs against hospital policy potentially and the Constitution, right? And officers are real quick to point out, and they're rightfully so, that they don't want to violate this person's Fourth Amendment rights from seizure, unnecessary search and seizure. And so what I would encourage everybody to do would be make your general counsel, your legal folks, your policy generators within your organization come together and talk through this and create a system or hospital policy based on the size of your organization that can be trained and then used across all of the teams that are not involved with your public safety or law enforcement function. And then have your public safety and law enforcement folks receive that and develop internal policy or general order to cover how you're going to manage it. And then have this conversation with your partner university agencies or your municipal or county or state agencies that apply to you. It's a huge deal, and there is very little case law across the country on how to manage AMA, but it is a huge concern. In Indiana, we're fortunate in that the statute that authorizes hospital police agencies allows us to enforce hospital policy. Now, we know the Constitution overrides state statute, but there's a way of threading the needle on doing that. So if it's a problem for you, I'm sure the folks on this panel will be happy to walk you through how they do it. I'll do the same for you. But coming from outside hospital policing, that was one of the most significant areas that I'd never thought would be an issue, but it is.
Great. Well, thanks everyone for a description and an elaboration on the challenges. Now we're going to move to really the meat of the webinar, and that is around solutions and potential solutions. Now, as we've seen and as we all know, this is an extremely rich area, so we're only really going to scratch the surface here. And the intent is to have a program of activities supported by the organisations, by IAHSS and IACLEA on an ongoing basis going forward. But so this is just a taste of the start of it. So what I would like to do now is invite the panel to talk through some of the solutions and opportunities for solutions that you see. So for some of the challenges that have been mentioned so far, what does your organisation do specifically to manage the challenge of managing safety across healthcare and educational areas? So Tommy, I'll lead off with you again.
Sure. Vanderbilt being as large as it is and being split from traditional campus and then the medical center, we kind of singularly approach threats and managing those threats and mitigating those threats as they occur. The approach we're taking now is developing a position that would manage as from an office all the threats that would face the enterprise of Vanderbilt Health at 100 Oaks, Vanderbilt University Medical Center, and Vanderbilt University campus. Because of the proximity of them all, one affects another. We had recently an individual that escaped custody from the city police, from the medical center, that immediately impacts and questions the safety of the students on campus. Of course, this occurs at 2 a.m. in the morning when it's dark outside and you want to make sure you keep everyone safe. But having someone that can bring together all of the collaborative partners from across the enterprise to make decisions, and everyone's in the room to put the best foot forward as an enterprise is the way we're approaching that, to be able to do that succinctly and pretty fast and efficiently.
And Tommy, is that someone from within the public safety department, or is that a nominated to executive level type relationship, or is there both in place?
So the position we're going for is going to be an executive position, preferably with a psychological professional background, but managed through the police department. Yes.
Okay, fantastic. Thank you. Bill, over to you. I know you've had really extensive experience, and we heard that before, and a lot of the a perspective on what's done nationally. So, could you describe some of the solutions you have in place for managing safety across these boundaries, and maybe some of the best practice you've seen around the country as well?
Well, thank you. Along the lines of what Tommy talked about a little bit, but we've implemented a combined protection model around what we call our shared purpose of protection, preparedness, and prevention. So the combined protection model are the 5 service areas that we have. We have healthcare security, we have investigative services, we have police services, we have risk management, and we have workplace violence prevention. So we did bring in a high level person to be part of the police department that works on workplace violence prevention, and his background is clinical. He is a registered nurse and so forth, and so we're building up that staff and that membership. But what we do with this combined is how do we integrate these services within the both organizations, and so part of that is we have a shared purpose council. We are part of all the tiered briefings. We have our behavioral intervention team for both campuses. We sit on the leadership organizations and leadership committees, and it's really about communications, and it's about relationships. And if you don't really have a seat as close to the C-suite as possible, and you're not part of all of the different strategic decisions that are being made, it's very difficult to carry out what we're talking about. Just an example, we have an institution-wide executive strategic planning session all day tomorrow. I'm invited, I'll be there, and we participate with executive leadership on that. So it's very important to build those relationships as you go along, making sure that even the reporting relationship with the chief executive of the police and security organization is either answering to the highest level, either the president or CEO, or no more than one level below that, if at all possible. Things like that is what's really going to put you in a position where you can be part of things before they get to be a crisis before this, because we have a prevention model. We don't have an arrest model. We don't have a law enforcement model. That's if we get to the point where we have to make an arrest, we've obviously failed at our first goal of preventing things. So it's very important for us to work with the different multidiscipline, cross-functional teams with all that wonderful expertise. You know, we just talked about the thousands of faculty and all the different things, well, the talent that's there and the understanding. It's very important because unlike a city, for example, where you might have a police officer that works in a certain geographic area of the city, which may be a certain group, predominantly, let's say it's a certain community. You don't have that on a campus. A campus, you have every culture in the world, literally. You have people from all over the world. It's a younger campus. Campuses are younger. The average age probably across the campus may be 25 or 26 at best. People are turning over every 4 years for the most part. Every one of your faculty members, if you're looking at the city analogies, is somewhat like a city council member. So it's just the way that you approach it is having those relationships and having people part of the decision. And that transparency that Mary talked about is very critical. It's having a partnership group that oversees the police agency that's part of solution. It's a problem solving group that goes out and helps you to solve problems so that you don't have just a police solution or just a security solution. And so that you can socialize what you're doing on campus so that you're part of the solution and everybody's part of that and coming together. So that's really the way we've approached it. Our combined protection model is integrated 5 levels of services towards our shared purpose. And it's worked very well for us, and you know, we're just continuing it.
Great. Thanks, Bill. And Mary, you've got a very wide span of responsibility across all of these different scenarios. What do you have in place as some of the solutions for managing student safety, staff safety in the medical environment? And I know you're on a journey of modernization as well. Do you have any plans for the future too?
Well, I always use the analogy of I never give out my business card on game day, you know, so I learned that in planning. And so if you don't know, like Bill said, if I don't know the chief executive officer of each one of my hospitals, I'm not doing my job. If I'm not on a first name basis with everybody, whether it be on the clinical side, the education and the research side, I'm not doing my job. I should never, I've been here 2 years and I have a mentor here in my environment who's been here for years. I also now mentor new leaders that come into our group. So I exchange information, I exchange what my values are, what our department does, both on the clinical side, education and research. And as those new leaders join, I know all the leaders, I sit in the C-suite on a regular basis. But as new people come in, I explain to them what the philosophy is, what our end goal is, how together we can be successful. So it's wonderful, you know, leadership changes a lot. And so you can have these great plans in place, but if you're not out there meeting and greeting the new person that joins the organization, and at UMMC, when I came on board, I was immediately put into the senior leader mentor program. That has helped me drastically. That has opened doors for me and taught me how to get everything done. You know, when you come on as the newbie, you could have 35 years experience like me, but it's all new. And then meeting those individuals and learning that pathway to how do I get this? How do I get buy-in? Buy-in's huge. So when I say, if I were you, this is what I would do in the clinical setting. I would do this. This is what law enforcement can give you. And so I also look a lot for grant monies on how, because budgets are so tight nowadays. So I also do, with my researchers, look at grant opportunities to help clinical and a conduit between clinical and the police department and education. And what can we all do together through a grant that we can prosper from? So I look at a lot of different, there's a lot of prongs on my fork here. It's knowing who your partners are, continually meeting your partners, looking for ways that we can grow together. When we talk about multidisciplinary, I'm a queen of that. You look at discover your strengths, communication is the key to success and survival. And so being a great communicator, and maybe that's not your strength, but somebody on your team is that great communicator. So find that person and leverage that to continue to grow and then to bring other people into your environment.
Yeah, relationships and communication are key in all of this. Thanks, Mary. Doug, you seen things from both sides most recently, both on the healthcare side and on the education side. So what do you do with regards to maintaining safety where you've got people from an education environment on your facilities now, and maybe what have you done in the past, and what best practices have you seen?
First off, everything my colleagues have expressed is spot on. And I think to take that a step further, acknowledging that we in law enforcement don't have to be in charge of everything all the time. You know, we've got wonderful emergency management folks and environmental health and safety folks and physical security and access control folks. So knowing who they are wherever you're at, and then knowing a person who's much smarter than me told me, she said, essentially make those that are in your wheelhouse, in your professional circle, those that if you have to gain buy-in. So think about all the people that if you were going to try and sell a concept to gain buy-in, get to know them and make them part of your network. To the point of we don't hand out business cards at the emergency, right? So if you take all these folks, these disparate functionalities across your enterprise, and you get to know them and you have lunch with them or coffee, or you just stop in and say hi, and obviously be genuine about it. But when you get to know those folks, when it's your time to be in charge of something, or you need to pitch and sell something, now you know all these people and they know you. And that can help you move whatever public safety agenda forward that you're trying to promote. So I like everything I've heard, and I would consider those things as well.
Fantastic. Thanks, Doug.
Glenn, if I could
Let's
just
go.
add one thing too, I think one of the critical things that makes you really successful, we kind of touched on a little bit, is diversity. If you're going to be serving in these institutions, diversity is absolutely critical. And I need more than just race and sex, but we're talking sexual orientation, we're talking age, we're talking about interest, degrees, the whole knowledge set. And if you don't have diversity, it's going to be really difficult to reach, touch, and understand the different groups and different components that make this great big machine called an academic medical institution move forward. And so I would tell you that the diversity is critical. Number two is on the diversity part, we in policing in general, and I'm not speaking to my colleagues here, but in general, we have failed miserable when it comes to having female representation in this line of work called law enforcement. And that's something that I think if we're going to correct things, we've got to do that. We've got to do that in a big way. So I'm a big proponent. You can look across the different successful institutions and organizations, whether it's even outside of policing. It's about diversity. It's about understanding those cultures, because the new generation that's coming on our campuses today, particularly in students, they're totally different. They're coming out of COVID. They're coming out of this technology thing. They just don't have the life skills that the older population did. Don't understand certain things, and they understand things that we don't understand. So it is important to have diversity across the board, and I just think that's critical.
Yeah, it's a fantastic point. Just leveraging off that, and this is just an open question to the panel here. Obviously, Bill, you mentioned about the new cohort coming in, and there seems to be an attendant mental health crisis in society, but also with the younger generation from the technology perspective, maybe coming out of COVID as well. With your organizations, as you work across the student and academic population, which trends younger, to the medical staff population, which are more mature, do you see any differences or challenges with how mental health and well-being is managed in your organizations? Obviously, in a healthcare environment, you might have employee assistance programs. In an education environment, you might have counselling and psychological services and feel more ownership for the younger generation. And does anyone want to make a comment on the challenges and maybe some of the solutions there? Yeah, Mary.
Behavioral threat assessment is my answer to that. And today, fortunately, here in Mississippi, we are hosting with IHL as my partner, behavioral threat assessment. We have all of our institutions here today. As a big advocate of behavioral threat assessment and a multidisciplinary team coming from Washington, D.C., it's not real popular in the state that I work in. It's not real popular in the healthcare industry. My local federal law enforcement agencies don't know behavioral threat assessment. So that's something, as I modernize the police department, I'm a huge advocate of it. And I'm a huge advocate of it. I know it works. And I know to look at when people are on the pathway to violence. And I think when you talk about psych patients, and you look at, there's nowhere really, when we were law enforcement officers in the city, where we used to be able to drop folks off. Well, that's where the other agencies are dropping them off, in our jurisdiction. So we're police chiefs, and we're hospitals where we have psych wards, and then they get released and they stay in our community. So that's like all about behavioral threat assessment, training your team to have those tools coming together. We have the best resources at a hospital because we have all of the trained professionals on the psych side. And then taking that with our education piece, then teaching our doctors, our future doctors, that let's run a behavioral threat assessment on the parent who's coming to the children's hospital that seems like they're really odd. We don't know if it's just because the child is sick. So we're using all those tools, but we're also educating the clinical side on how we do a behavioral threat assessment. What does it look like? We use software. I'm the only person in the state that has the software. It's called ONTIC, does a deep dive onto the web. I'm able to share that confidentially with my colleagues and the students as to, hey, this person poses a threat, or this is what we need to do with this person. And so I think that the police department has a lot of unique tools that we then share with healthcare. And then it's a holistic approach rather than healthcare makes a determination on someone being sick or their parent coming to visit. I think combining those and bringing it interdisciplinary to make a decision on whether it even be one of our students that's going through a mental health crisis. I think behavioral threat assessment, looking at that and assessing it and then working together is the key to success there.
Yeah, Bill, go ahead.
Piggybacking on what Mary said, she's absolutely right. Using protective intelligence, using these cross-functional teams is important. In the medical area, I know they have ROSET, they have these judgment tools that they can use, but bringing all the different things together is important. But I also think that on the side of employees, you talked about employee assistance programs, counseling. It's not just something that we need to be very cognizant of in terms of our students, whether it's medical students or other students, but also for our own personnel. We're talking about peer support. We're talking about everything. We've created a system-wide. We're part of UT's system, one of the largest, second largest academic system in the nation, second largest endowment behind Harvard, obviously, and soon to pass Harvard, I will say. But that said, it's very important that we have this peer support. What are we doing for our own employees? I don't think that police officers have been under so much pressure as they are today. We know that we're having trouble getting good qualified candidates into our policing agencies. We've had a lot of high profile cases and we've had a lot of people exiting the profession. A lot of it was it was time to retire. So what we have to do is we got to make sure that we're overtaxing the existing resources, that these men and women have the necessary mental health support that they can. And that's very critical. So I'd also say that if you don't have a peer support program within your own agencies here on these campuses, it's something you should truly look at.
I would piggyback on the threat assessment. It's really important that the police aren't the only people making the decision. The threat assessment allows us to make decisions with our partners so that everyone's included every step of the way. So when we arrive to resolution or the planned steps, no one feels left out. They feel they contributed, and we're able to get the best perspective from every area, whether it's on the student side to include support services through counseling or medical leaves to get them the services they need away from campus and mitigating threats that way. From the employee side, whether it's fitness for duty testing to ensure that someone's in a good space to be able to work here, and also to piggyback my colleague, testing at least every other year of the mental health space and health of our officers to ensure that they're in a space to deliver satisfactory service delivery to the community.
Fantastic. So we're approaching the end of the webinar. We'll open up to Q&A very, very shortly, and there's been a few questions from participants. So a message to the participants, please add questions you have in there. Mary, there's one little thing you mentioned in your last comment, and that was around, sounds like you're being mindful about new people coming into the environment. It sounds like you have maybe either some programs or training or handling new people in the environment intentionally, knowing that they're coming from a different perspective and they're coming into this situation. Could you maybe expand on that a little?
Well, the academic and clinical side has a doctor that oversees anyone that's coming into the organization in a leadership role. And they do a determination whether they go into the mentorship program. So then there are mentors within the organization. I happen to have been mentored and then rose to the level of a mentee. So now I am on that committee. So a new person comes into the environment, an announcement is made that so-and-so is a new academic person for this area. And then I spend time with them. We do an intro. I tell them about but they get key personnel that kind of get them on the path or as feelers out there to get them where they need in this. It's a great system that my institution has in place that I was successful in. And then I became part of that. I really love it because I haven't had that in other organizations I worked for. And so it's a learning curve. I don't care, like I said, how many years experience you have to learn how things are done and how to get the resources you need. Because, you can go to a web page and look for hours or whatever, but a real live person that's your contact person. Like I have to this day call my mentor. I'm like, hey, I don't understand this. Why does this happen? And he's wonderful. And then he'll put me in the right direction. I've become that over 2 years to other folks. And that when we talk about relationships, they're like, oh, I met Chief Parity when I first got here. She was in my mentorship program and I know her. And so I think the university does, as a whole, leadership does a great job at interfacing all these different people into bringing them in and making them feel welcome.
Thanks, Mary. All right, we'll hand over to some Q&A, and there are a few things that we can follow up with after, but a general question for the group here is, are you responsible for your offsite medical and clinical locations, and what are maybe some of the challenges there in those more remote, uncontrolled circumstances, especially where you may have academic staff or students in those locations? Anyone like to add a comment there? Yeah, Doug, go ahead.
Great question, and for us, it's a moving target. Our corporate real estate entity procures a lot and gets rid of a lot. So staying on top of what all you have is a challenge. I think you have to figure out what's the best solution for that location based on where it's located. So right down the street from one of our big hospitals is an urgent care. Well, the Indianapolis Metro PD and the IU Health DPS can respond to that for emergencies and non-emergencies. That's easy. Something out in the middle of nowhere in southern Indiana is a bit more of a challenge. And so relationships, again, going back to relationships with those local first responder agencies in that location in southern Indiana are important. One other thing, though, that really, and anymore, it's important across the board for everything we've talked about, is a solid relationship with your IT or IS folks. Because a solution, whether it's close to one of our properties or if it's out by itself, is going to have some facet of a IT or technology solution integrated into it. So the more your IT folks are talking with you and you're talking with them, and you're talking with your partner agencies and their IT folks, I think that's critical.
I want to add, I think some of the outposts, a big challenge that I have in rural Mississippi is recognizing domestic violence and human trafficking, because we're a healthcare facility. So those are two things that come to those environments that I'm very cognizant of, that making sure that my folks, I use HR as my conduit for that, because I say to HR, when you're having a training, I want to not only talk to my local law enforcement partners in that community, but my clinical people, to ensure they understand what are the flags of human trafficking and what does domestic violence look like, and their requirement to report. So that's where I think that it's a really good way. And then I make HR touch with all those employees, and I'm able to push out a police safety and security message to them.
If I could, the other big thing for all of us in academia is that in those locations, if there's any trainees or any students out there, you've got a clery requirement. So you may not staff it, but you're certainly going to have to work with the local law enforcement. That's where MOUs come in. That's where really knowing what's going on, so that you can properly put out clery notices, or that you can do your annual report. So it's going to be, and the geographical makeup of all that. And it's like Doug says, if things are coming and going, it's just tough to keep up with all the clery locations. So for us in this business, it's just more than just staffing and covering. It's all about relationships. So I go back to what Mary or Doug, I think, said, that it really depends on what the operation is, the size of it, the complexity of it, the problems that they're having. You have to do a risk and threat assessment to determine whether you need to be asking for the resources. And then is how do you really supervise or oversee certain things? But the IT connection is very, very critical, because almost every one of those facilities will have camera systems, they'll have card access systems, some of them will have screening systems, weapons and other passive screening systems coming in. And a lot of them will even have alarm systems for after hours if they do close. So yeah, it's a moving target. It's very complicated, but again, I stress that just complying with the Clery Act is going to be very, very challenging.
Absolutely.
Here at Vanderbilt, for those outposts that we have, We put third-party security there. We also manage those connections with law enforcement agencies in those counties. We assigned a captain specifically to manage that portfolio of those outposts. So there's a person dedicated to those responsibilities.
Mm. Mm. Fantastic. Well, we're nearing on time, and this, what we've seen here is we've really just scratched the surface of the challenges, and then also the potential solutions and the ways organizations are operating, and that really shows us and elaborates that this is a rich area that needs further engagement and collaboration. So I'd just like to ask all the attendees here, maybe you could spend 30 seconds on, or a minute, on what you would like to see in terms of a collaboration going forward between IAHSS and IACLEA, and what opportunities there may be. So Doug, would you like to go ahead?
I think I'd like to see a sharing of best practices. I think, at least in Indiana, hospital police are where our university police were about 10 or 15 years ago. I think university police do a lot of things well that municipal agencies, for example, could learn from. So a sharing of best practices and the sharing of challenges and issues.
Great. Tommy?
Yes, so when I think of both of these entities, the space that I think that works, some places have police officers, some have just security. The response for that in an active shooter or active assailant scenario is quite different. And what does it take to evacuate on the campus side versus what does it take to evacuate, or whether you should evacuate in a medical center setting? Something to come together to make sure that that's cohesive and you can go to one space to find that guidance.
Yeah, so best practice in critical incidents across these boundaries. There's obviously a real opportunity area. Great. Mary, do you? Oh.
I love the idea of a more frequent working group. I'm all about bringing in something like when we talked about if you don't have a hold on an individual, and when they're running down the street with they're connected to IVs and all that, and then they want police officers to chase after them. Talk about a great working group, not just for the leaders, but for our next level down to be able to say, oh yeah, that's a challenge. We're like, we need a 72-hour hold. We can't do this. I loved hearing that from the other, because that's a challenge we have. I think that a roundtable working group would be great, and then sharing those with all the larger group.
Fantastic. And Bill, you've been deeply engaged with both organizations, IACLEA and IAHSS, so over to you about the opportunity you see there.
Oh, it's a wonderful opportunity. You have IAHSS that has particular expertise in the hospital arena, Joint Commission standards, that type of accreditation. They're really working heavily now in the workplace violence space. They do a lot on security. They have certification programs for security managers. All those areas there is wonderful. They have that in place. You go to IACLEA, now you've got the students issue. They've been really big in the behavioral intervention teams. They've been really big in the CleRI, student health. They're really, that's the police side of it. There's more in the police department. They actually have a wonderful accreditation program. So I think that they could come together and look at accreditation programs for security, not just policing. I think they come together and look at the different accreditation requirements for best standards, whether it's a hospital Joint Commission standards, or whether it's, CLEA, IACLEA, or some of the other standards that are in place. How can we best take the best of both of those organizations and meld them together? And I think they can do that in a very responsible and a very successful way for both organizations. But if you're in the academic medical center, you really need to be part of both organizations and really taking advantage of the expertise. They have wonderful standards. They have books. They have experts that are members of both organizations that are willing to help you, willing to make outreach. They're willing to be peers with you on whatever it is that you're doing. So yes, they need to come together. And by the way, Glenn, I want to personally thank you and your organization for bringing this together and making this the beginning of many more steps and many more webinars, I'm sure. But to bring these two organizations together so that we can better the academic medical campuses and just do a better job for all of us. So thank you, Glenn.
Yeah, thank you, Bill. And on that note, I'd like to thank all the attendees to the webinar and taking their time out, and especially our panel here. Thank you very much for sharing your experience and being here, everyone being here at the ground floor of this initiative. And we're really proud to be involved as well. If anyone is interested in a next step at the IACLEA conference in Orlando at the end of the month, Doug will actually be involved in a session along with Eric Clay, the president from IAHSS. And it's really an opportunity to see the perspective from the IAHSS side, but in the IACLEA context. So that's an obvious, concrete next activity. So hopefully we'll get a chance to catch up out there in Orlando, but looking forward to the next opportunity as well. Thank you everyone for your time, and be safe. Thank you.